Welcome to the Hospital Medicine Unplugged podcast.
Great to be here. We're diving deep today into, well, one of the most critical and frankly high-stakes clinical scenarios we see in inpatient medicine.
Absolutely. We're talking about the evidence-based diagnosis and management of acute PUB, that's peptic ulcer bleeding.
Right, PUB.
And our mission today really is to try and synthesize this huge amount of information, the guidelines, the research, and give you, our listeners, a kind of high-yield, actionable roadmap, how to manage this emergency from the second the patient arrives right through to discharge.
And it's so vital because PUB, it's not some rare thing. It's actually the most frequent cause of non-variceal upper GI bleeding we encounter.
That's right. The numbers really underscore why this is important.
They do. The clinical burden, it really demands our attention. You're looking at over 500,000 hospitalizations every year just in the U.S. for upper GI bleeds and peptic ulcers. They're driving almost half of those admissions, maybe around 50%.
And while you might look at the overall mortality numbers, say 2% to 10%.
Which might sound relatively low.
Right, but that figure, it can be really deceiving, can't it?
Hugely deceiving. And here's the critical point, especially for hospitalists.
Yes.
If a patient develops an upper GI bleed after they're already in the hospital for something else.
Like pneumonia or maybe heart failure.
Exactly. Say they're 3 days into their admission. Their mortality risk from that bleed, it jumps dramatically.
How much higher are we talking?
The data suggests it's 3 to 4 times higher. That in-hospital UGIB carries a much worse prognosis compared to someone coming in specifically for the bleed.
So we're often dealing with sicker, more complex, maybe more fragile patients to begin with.
Precisely. And that just highlights why we need such a precise, protocol-driven approach, guided by the best evidence.
What's what we're planning to unpack today.
Exactly.
Okay, so let's start right at the foundation. Etiology and risk stratification. We need to understand why this is happening before we jump to fixing it.
Makes sense. So the basic mechanism, it's straightforward, but, potentially devastating.
Right.
You have a pre-existing mucosal defect, the ulcer itself, and it erodes down. It breaches into a submucosal blood vessel.
Leading to the hemorrhage.
Leading to hemorrhage. Can be arterial, can be venous. Often it's because those normal defenses the mucosa has against stomach acid have failed.
And historically, we know there were two main culprits, two primary villains that account for the vast majority of these PUB cases.
That's right. They often work together, unfortunately. The most dominant cause still is Helicobacter pylori infection.
H. pylori accounts for maybe, 40-something%?
About 42% of cases, yeah. This bacterium, it sets off a chronic inflammation, which doesn't just damage the mucosal barrier directly, but also, and this is crucial, it ramps up acid secretion, both basal and stimulated.
Creating this hostile environment that prevents healing and just promotes more erosion.
Exactly, and you see that reflected in the relative risk. Just having H. pylori carries an RR of about 2.6 to 2.9 for developing PUB.
Okay, so that's villain number one. What's the second major driver?
The second group, causing maybe around 36% of cases, involves NSAIDs, that's non-steroidal anti-inflammatory drugs, and also aspirin use.
NSAIDs and aspirin. How do they cause the damage?
It's a bit complex. So NSAIDs inhibit the COX-1 enzyme.
Right.
And that blocks prostaglandin production. Now, prostaglandins, they are absolutely vital for mucosal health. They maintain blood flow, promote mucus, and bicarbonate. They keep the lining intact.
So take away the prostaglandins and the mucosa is left vulnerable. Plus, the NSAIDs themselves can cause direct injury, right?
Exactly right. Direct topical epithelial injury. And the risk profile is actually higher for NSAIDs alone compared to H. pylori alone. The RR for NSAIDs use is around 4.0.
4, okay. And low-dose aspirin?
Low-dose aspirin, like the 81 milligram dose, still carries risk. An RR of about 1.9 to 2.2.
But the real danger zone is when these overlap.
That's the most alarming point and something we really have to stress. If you have someone with an uneradicated H. pylori infection and they're taking NSAIDs, that relative risk for PUB just skyrockets. It can be up to 8.0.
8 times the risk. That's huge. That synergy is like a ticking time bomb.
It absolutely is.
And beyond those two big ones, H. pylori and NSAIDs aspirin, we have to be looking for other factors, especially in our hospitalized patients who often have multiple issues.
Definitely. That list includes, the usual suspects. Antiplatelet agents beyond aspirin, anticoagulants, corticosteroids.
Especially steroids with NSAIDs, right? That combination is particularly bad.
Dramatically increases toxicity, yes. And then there are some less obvious ones we need to keep in mind, like selective serotonin reuptake inhibitors. SSR.
How do SSRs increase bleeding risk?
They seem to interfere with platelet function, specifically serotonin transport within the platelets, which hampers their ability to aggregate properly.
Interesting. Okay, so the patient arrives, maybe unstable. We have this potential web of causes. The immediate need is to figure out how sick they really are. Who needs the urgent intervention?
Exactly. And this is where pre-endoscopic risk assessment is invaluable, specifically the Glasgow Blatchford Score, or GBS.
The GBS needs to be calculated right at admission.
It's mandatory, really. It's such a useful clinical tool because it only uses information that's available right away. You don't need the endoscopy results.
It combines clinical findings and some basic labs. Can you walk us through the components?
Sure. It looks at blood urea nitrogen, or BUN.
BUN.
Hemoglobin concentration, systolic blood pressure, pulse rate, and then aspects of the presentation. Did they present with melena? Did they have syncope? And finally, any history of hepatic disease or heart failure. Those comorbidities matter.
Now, the inclusion of BUN is interesting. It's not just about kidney function here, is it?
That's a really key insight. No, in UGI bleeding, a high BUN is acting as a proxy for a couple of things. One, it reflects a significant protein load from digested blood in the GI tract. And two, critically, it often signals prerenal azotemia kidney injury due to low blood volume from the bleed itself.
So a high BUN suggests significant volume loss and a large bleed.
Exactly. A BUN over 25 milligrams per deciliter gets a lot of points on the score because it strongly suggests a major hemorrhage.
So the GBS is synthesizing the amount of blood lost, BUN, HTB, with the body's response, BP, pulse, syncope. What's the critical score threshold we're looking for?
The real power of the GBS is in identifying the patients who are truly low risk.
Okay.
A score of less than or equal to 1, so 0 or 1. These patients have an extremely low chance, less than 1%, of needing any urgent intervention like transfusion, endoscopy, or surgery.
And clinically, what does that mean for them?
It often means they may not even require hospital admission. They can potentially be managed safely as outpatients, which is huge for resource allocation.
That is a powerful tool. So GBS 0 or 1, maybe outpatient. What about everyone else?
For everyone else, anyone scoring 2 or higher on the GBS, urgent intervention and hospital admission are absolutely non-negotiable. They are high risk.
Okay, so we've used the GBS, identified a patient as high risk. The clock is ticking. This leads us straight into the next big pillar. Immediate resuscitation and pre-endoscopy stabilization.
Absolutely. This is your ABCs. Priority 1 is getting IV access, prompt, rapid access, and starting crystalloid resuscitation to restore peripheral perfusion.
And we need good access, right? Not just a tiny IV.
Cannot emphasize that enough. Large bore access. Ideally, 2 large IV lines, because you might need to give volume quickly.
What's our target hemodynamically? We hear about avoiding overly aggressive resuscitation sometimes.
That's right. The goal is to maintain systolic blood pressure roughly between 90 and 100 millimeter Hg, that's millimeters of mercury, until you know the major bleeding is controlled.
So not necessarily pushing for 120 systolic right away.
No. The danger of being too aggressive, pushing the pressure up too high too fast, is twofold. First, you can dilute the clotting factors they still have. Second, you might actually raise the pressure enough to dislodge a clot that was starting to form at the bleeding site and restart the hemorrhage. So the aim is stabilizing perfusion, getting it adequate, not necessarily making the numbers look perfect immediately.
That philosophy fits perfectly with the transfusion strategy discussion, the whole restrictive versus liberal approach. The evidence seems pretty clear here.
Very clear. The data from major trials, like that big one in the NEJM back in 2013, strongly supports a restrictive transfusion strategy for most patients with non-variceal UGIB.
So what's the trigger? When do we actually transfuse red blood cells?
The general trigger, the threshold, is a hemoglobin below 70 to 80 grams per liter.
Okay, 7 to 8 grams per deciliter.
Correct, transfusing below that level.
And why is keeping it restrictive, aiming for that 7 to 8 target, better than, say, transfusing earlier when it drops below 9 or 10?
Well, the restrictive strategy has actually been shown to reduce mortality and also reduce rebleeding rates compared to a more liberal strategy.
Interesting. Why would that be?
The thinking is, it likely relates to avoiding the known risks of transfusion. Things like volume overload, potential immunosuppression, and maybe even effects on splanchnic circulation that could impair mucosal healing.
But, like most things in medicine, there's an important exception to that 7 to 8 rule.
Absolutely crucial exception. Patients who have known active cardiovascular disease.
Like a recent MI, unstable angina, severe heart failure.
Exactly. Those patients tolerate low oxygen carrying capacity very poorly. So for them, we use a higher threshold. Aiming to keep the hemoglobin maybe around 100 grams per liter or 10 grams per deciliter is generally considered safer.
Okay, so volume is being addressed, transfusion strategy is set. What about clotting? If a patient comes in with a known coagulopathy, or maybe they're on anticoagulants.
We definitely need to address significant coagulopathy, especially if endoscopy is planned. The general target is usually to get the INR below 2.5 before the scope, if it's feasible and time allows. But it's a bit nuanced. The evidence isn't super strong that routinely correcting mild coagulopathy, like an INR, just a bit over 1.5 in someone not on warfarin, actually improves outcomes specifically in non-variceal UGIB.
So it needs some individual judgment based on how bad the bleed is, how high the INR is, and what procedure is planned.
Precisely. Individualize the approach.
Okay, now shifting to pre-endoscopy medications. The immediate use of an IV PPI seems like a standard non-negotiable step.
Absolutely non-negotiable. It should be given as soon as the patient is reasonably stable and you suspect PUB.
And the rationale there?
It's simple but powerful. Early, potent acid suppression with a proton pump inhibitor raises the stomach pH.
Right.
And that higher pH environment helps stabilize any clot that's already formed over the ulcer and makes the clot stronger and less likely to break down.
So it buys time and potentially improves the view for the endoscopist.
Exactly. Studies confirm that starting IV PPI early significantly reduces the chance of finding those really high-risk stigmata, like active spurting or a visible vessel when the endoscopist goes in, makes the procedure potentially safer and more effective.
What about other meds before the scope? Sometimes we hear about giving something to clear out the stomach.
Yes, prokinetics can be helpful. Erythromycin is often used. Specifically, 250 milligram IV given about 30 to 60 minutes before the procedure.
And that's not treating the bleed itself?
No, not at all. It's purely mechanical. Erythromycin stimulates gastric motility. It helps clear out residual blood, old clots. Basically improves visualization for the endoscopist.
Which could mean a faster procedure, maybe less chance of needing a second look.
Correct. It can really make a difference in getting a good, clean view the first time.
Just as important as knowing what to give is knowing what not to give. What medications should we avoid in this acute PUB setting?
Right. Good point. Despite maybe seeing it used sometimes, tranexamic acid is not recommended routinely.
Okay, no TXA.
The evidence just hasn't shown a consistent benefit in non-variceal UGIB. And also, H2 receptor antagonists like ranitidine or famotidine, they're simply inferior to PPIs for the level of acid suppression needed here. So stick with the PPI.
Got it. And we have to make a special mention for patients with cirrhosis, right? Their bleeding risk and management are different.
Absolute critical distinction. If a patient presenting with UGI bleeding has known cirrhosis, you can't just follow the standard PUB pathway initially.
Why not?
Because the likelihood of variceal bleeding is so high, you have to assume it could be varices until proven otherwise. So standard PUB protocols need immediate additions.
Like what?
Prophylactic broad-spectrum antibiotics are indicated right away to prevent SBP, spontaneous bacterial peritonitis, and vasoactive agents like octreotide should also be started immediately to lower portal pressure.
So for cirrhotic patients, antibiotics, octreotide, plus the PUB workup in parallel until the source is confirmed.
Exactly. Don't delay those specific cirrhosis interventions while waiting for endoscopy.
This brings us nicely to the timing of that endoscopy. Given how sick these patients can be, there's often pressure to get the scope done ASAP. What does the evidence actually say about the optimal timing?
The standard evidence-based recommendation is that endoscopy should be performed within 24 hours of presentation.
Within 24 hours, not necessarily within 6 or 12 hours.
Correct. That 24-hour window allows the necessary time for adequate resuscitation and stabilization first. And that stabilization is the key factor driving outcomes, much more so than the raw speed of getting the scope done.
So rushing an unstable patient to endoscopy might actually be harmful.
It can be. Studies comparing very early endoscopy, say within 6 to 12 hours, versus routine endoscopy within 24 hours in stable patients, they show no difference in mortality or rebleeding rates.
Okay.
Furthermore, if you do rush an unstable patient, you significantly increase the risks associated with the procedure itself, risks from sedation, potential aspiration, even hemodynamic collapse during the scope.
So the mantra is stabilize first. Get the blood pressure up to that 90-100 systole range, transfuse if needed based on the HGB, start the IV PPI, and then proceed with endoscopy safely within that 24-hour window.
That's the non-negotiable prerequisite. Stabilization buys you the time for a safe and ultimately more successful procedure.
Okay, stabilization achieved. Patient is heading to the endoscopy suite. Once the scope is in, the endoscopist is using the Forrest classification. Explain that for us.
The Forrest classification is absolutely fundamental. It's how endoscopists categorize the appearance of the ulcer base.
And why is that important?
Because the appearance directly predicts the risk of the ulcer rebleeding if you don't intervene. And that prediction then dictates the need for endoscopic therapy.
So which findings constitute high-risk stigmata that demand intervention?
The high-risk ones are Forrest 1A, that's active arterial spurting; Forrest 1B, active oozing hemorrhage; Forrest 2A, a non-bleeding visible vessel. You can actually see the vessel sitting in the ulcer base; and Forrest 2B, an adherent clot that you can't easily wash off.
And the rebleeding risk with those is significant.
Very significant. If left untreated endoscopically, those lesions have a rebleeding rate of 50% or even higher. Intervention is mandatory.
What about the low-risk findings? When can the endoscopist say, okay, no intervention needed here?
The low-risk findings are Forrest 2C, which is just a flat, pigmented spot in the ulcer base, maybe old blood, and Forrest 3, a completely clean base ulcer.
And the risk there?
Much, much lower. Rebleeding risk is typically less than 5%. So for Forrest 2C or 3, generally no endoscopic hemostatic therapy is required, which simplifies post-procedure care quite a bit.
Right. So for those high-risk lesions, the spurting, oozing, visible vessel or adherent clot, the standard of care, is what's called the dual modality mandate. Explain that.
This is a really key principle in PUB management. Dual modality means using 2 different endoscopic techniques to stop the bleeding. It's demonstrably superior to using just one method or monotherapy.
Why is 2 better than 1?
Because it significantly reduces the risk of rebleeding, reduces the need for a repeat endoscopy later, and lowers the rate of needing surgery down the line.
Okay, so what's typically the first modality used?
We usually start with injection therapy.
Using epinephrine.
Correct. Usually a 1.10,000 de la Sorec dilution of epinephrine injected around and into the bleeding point.
How does that work?
It works in 2 ways. Chemically, it causes vasoconstriction, clamping down the vessel. And physically, the volume injected creates a tamponade effect, compressing the vessel.
But you said it's usually not enough on its own.
Right. The effect of epinephrine alone tends to be temporary. Rebleeding rates are unacceptably high if that's all you do, so you absolutely must follow it up with a second, more definitive modality.
And what are the options for that second modality? They fall into a couple of categories.
Generally, yes. You have thermal therapies and mechanical therapies.
Okay, tell us about thermal.
Thermal therapies use heat to coagulate tissue and seal the bleeding vessel. This includes contact probes like bipolar electrocoagulation or a heater probe where the device touches the tissue. Or you can use non-contact methods like argon plasma coagulation, which is great for more diffuse surface oozing.
And the other category, mechanical.
Mechanical therapy primarily involves using hemoclips. These are little metal clips that are deployed through the scope to physically clamp the bleeding vessel shut.
And how do clips compare?
Clips are very effective. They provide definitive compression, and studies show they are superior to just epinephrine injection alone in reducing rebleeding. They're a mainstay.
Now, there's some newer tools available too, right? Like over-the-scope clips, OTSCs.
Yes, OTSCs are a significant advancement. They're much larger clips deployed using a special cap on the endoscope.
What's the advantage?
They can grasp a much larger amount of tissue, including the vessel, providing a really robust, durable mechanical closure. They're often considered a first-line option now, especially for large ulcers or difficult-to-treat bleeding sites.
And the data supports their use.
Yeah, recent trials suggest OTSCs might actually reduce rates of persistent bleeding or recurrent bleeding compared to traditional dual therapy with injection, plus standard clips or thermal. So, a very powerful tool in the arsenal.
What about situations where things are really difficult? Maybe diffuse bleeding, poor view. Are there other options?
Yes. For those really challenging scenarios, we have hemostatic powders. TC325 is one example.
And how do they work? When are they used?
These powders are sprayed onto the bleeding area. They absorb water, concentrate clotting factors, and form a kind of mechanical barrier. They are typically reserved for rescue therapy.
Rescue therapy meaning?
Meaning, when standard methods like injection, thermal, or clips aren't feasible or have failed, maybe it's diffuse oozing from a large area, or the visualization is just too poor to target accurately, the powder provides a temporary stopgap, buys time for the patient to stabilize, maybe allowing for another attempt later or a different intervention.
Okay, so what happens if that initial well-performed endoscopic therapy just fails? The bleeding continues or restarts right away. What's the next step?
First step is always re-stabilize the patient hemodynamically. Then repeat endoscopy is the standard first-line next intervention. Go back in for a second look and another attempt at hemostasis.
And if that second endoscopic attempt also fails, we're talking persistent, refractory bleeding despite 2 good tries with the scope.
At that point, you generally need to move beyond endoscopy. The next step in the algorithm is usually to consider transcatheter arterial embolization, or TAE.
That's done by interventional radiology.
Correct. IR takes the patient, accesses the arteries feeding the stomach, finds the specific vessel that's bleeding using angiography, and then embolizes it, blocks it off, usually with tiny coils or sometimes gelatin foam.
How successful is TAE?
It's actually quite successful, often in the 70% to 90% range for stopping the bleeding, and it's much less invasive than traditional surgery.
So TAE is the preferred option after failed endoscopy?
Generally, yes. Surgery is then reserved as the definitive last resort option if both endoscopic therapy, 2 attempts, and TAE fail to control the hemorrhage, or if the patient is too unstable for TAE.
That clear, stepwise progression repeat endoscopy, then TAE, then surgery is really critical when things aren't going smoothly.
Absolutely. Having that plan is crucial.
Okay, so let's assume hemostasis was achieved successfully during the endoscopy. We move immediately into post-endoscopy management. And the cornerstone here seems to be the 72-hour rule for high-dose PPI therapy.
That's right. For any patient who had endoscopic intervention for those high-risk stigmata we talked about, Forest 1A, 1B, 2A, 2B, continuing high-dose PPI therapy for a full 72 hours is essential.
Why 72 hours? What's the goal?
The goal is to maintain a consistently high intragastric pH, ideally pH 6 or greater. That high pH environment is optimal for platelet aggregation and strengthening the fibrin clot over the ulcer base. It prevents the clot from breaking down prematurely, which is key to preventing rebleeding during that high-risk window.
Now, for us hospitalists managing these patients on the floor, there used to be a lot of debate about how best to give that high-dose PPI, continuous infusion versus intermittent boluses. What does the evidence say now?
The good news is we now have high-quality evidence showing that both common regimens are equally effective.
Okay, what are the 2 options?
Option 1 is the traditional continuous infusion. Typically an 80 milligram IV bolus, followed by an 8 milligram per hour continuous infusion for 72 hours.
Right.
Option 2 is intermittent dosing. This is usually giving a high dose like 40 to 80 milligram, either IV or even orally, twice a day every 12 hours for those 72 hours.
And the data confirms they work just as well.
Yes. High-quality randomized controlled trials have shown that intermittent high-dose PPI is non-inferior to continuous infusion PPI in preventing rebleeding, need for surgery, and mortality.
That's a really important clinical takeaway. It gives us flexibility based on staffing, IV access, unit protocols.
Exactly. It allows for adapting to hospital resources without compromising patient care. Both are evidence-based and effective for those crucial first 72 hours.
So after that initial 72-hour high-dose period, what happens next with the PPI?
After 72 hours, you transition the patient to oral PPI therapy for longer-term healing and prevention.
And what does that oral regimen usually look like?
For most patients who had a standard ulcer bleed, transitioning to a once-daily oral PPI is usually sufficient.
Okay.
However, if the patient was particularly high risk, maybe they had a very large ulcer, significant comorbidities, or a history of prior bleeding, some guidelines suggest continuing twice daily oral PPI for another 10 to 14 days, then stepping down to once daily. The total duration of PPI therapy is usually at least 2 to 4 weeks, sometimes longer, depending on the underlying cause and need for ongoing gastroprotection.
Got it. Now, what about feeding these patients? Historically, there was a lot of fear about letting them eat, keeping them NPO for days.
Yeah, that NPO till the cows come home approach.
Right. Fear of restarting the bleed. What's the modern take?
The evidence here is incredibly clear now, and it completely flips that old practice on its head.
Okay.
Initiating oral or enteral feeding early, meaning within 24 hours after bleeding control has been confirmed endoscopically, is not only safe.
Safe meaning it doesn't increase rebleeding risk.
Correct. It does not increase the risk of rebleeding. But beyond just being safe, it's actually beneficial.
How so?
Early feeding reduces the patient's overall length of hospital stay. It improves their nutritional status, obviously, and it's now considered the standard of care once the patient is hemodynamically stable and the bleed is controlled.
So get them eating within 24 hours if possible. Great. Given that the highest risk of rebleeding is in those first few days, particularly the first 72 hours, what kind of monitoring do these patients need post-endoscopy?
Patients who needed endoscopic hemostasis for those high-risk stigmata require pretty intensive monitoring initially. The recommendation is generally placement in a monitored setting, like a step-down unit or even an ICU, depending on their overall stability for at least the first 24 hours.
And what are we monitoring specifically?
Key things are frequent vital signs checks, maybe every 2 to 4 hours initially, and serial hemoglobin or hematocrit checks perhaps every 6 to 12 hours for the first 24 to 48 hours.
Why that intensity?
Because, as you said, the vast majority of recurrent bleeding episodes, over 90% of them, happen within those first 72 hours. We need that close monitoring to catch any sign of rebleeding immediately, a drop in blood pressure, rise in heart rate, or a significant drop in HGB.
Makes sense. And the decision about when the patient can go home, the disposition, really hinges on this risk stratification and monitoring period.
Entirely. Low-risk patients, remember, those with the Forest 2C flat spot or Forest 3 clean base, who are hemodynamically stable, they can often be safely discharged relatively quickly, maybe even within 24 hours after the endoscopy, assuming good follow-up is arranged.
But the high-risk ones?
The high-risk patients, the ones who actually received endoscopic therapy, they really should remain hospitalized for at least 72 hours. That allows completion of the high-dose IV PPI course and gets them through that peak rebleeding window under observation.
Then thinking about prognosis overall, while our acute management is focused on stopping the bleed, what really determines the patient's long-term outcome?
That's a crucial point. Often, the mortality associated with PUB isn't directly from exsanguination, but rather linked to the patient's underlying comorbidities and baseline health status.
So things like age, other medical problems.
Exactly. Predictive scoring systems like the Hospital Score or the AIM-65 score, which incorporate factors like age, comorbidities, hepatic, renal, cardiac disease, and the initial hemodynamic presentation. These are strong, independent predictors of poor outcome and mortality. It confirms that older age and severe baseline illness are major drivers of risk.
Okay, this brings us to what feels like one of the most challenging areas for hospitalists: managing complex coagulopathy and antithrombotic medications in a patient who has just had a major bleed.
This truly is the high-stakes balancing act, isn't it? It's where clinical judgment becomes paramount.
Absolutely. We're constantly weighing the risk of the PUB recurring against the risk of a potentially devastating clot, an MI, a stroke, a DVT-PE.
And we have to recognize often that interrupting necessary life-saving antithrombotic therapy can actually be more dangerous in the long run than the potential risk of another bleed.
Let's break it down, starting with aspirin and other antiplatelets. Focus first on secondary prevention patients taking these meds because they have established cardiovascular disease, maybe a prior MI, known CAD, or a recent stent.
Right. For this group, the evidence and guidelines are quite clear. Continuing aspirin, or if it had to be held briefly, resuming it early, is essential.
Why is holding it so dangerous?
Because interrupting aspirin, even for a few days, in patients with established cardiovascular disease, is strongly associated with a significant increase in mortality and major adverse cardiovascular events, MC, especially things like acute stent thrombosis, which can be catastrophic.
So if it was held for the acute bleed, when should we aim to restart the aspirin?
The current recommendation is to restart aspirin within about 3 days, 72 hours, once you're confident that definitive bleeding stabilization has been achieved. It's about balancing that acute bleed risk against the very high chronic thrombotic risk.
Okay, that's secondary prevention.
Yeah.
What about the flip side? Aspirin being used purely for primary prevention. Patient has no known heart disease, just taking it based on risk factors.
Well, in that case, the calculation changes dramatically. For primary prevention, where the net benefit of aspirin is often marginal to begin with, if that patient then has a significant PUB, that event really tips the risk-benefit scale. The aspirin should generally be discontinued permanently, the bleed demonstrates their propensity, and the future risk outweighs the uncertain primary prevention benefit.
Makes sense. Now, what about those really complex patients on DAPT, dual antiplatelet therapy? Usually aspirin plus a P2Y12 inhibitor like clopidogrel or ticagrelor, or often after a recent stent.
Yeah, these are among the toughest decisions. This absolutely requires immediate, close, multidisciplinary discussion, particularly with cardiology.
What's the general approach?
The priority is usually to maintain the aspirin if at all possible. The P2Y12 inhibitor might need to be held briefly during the most acute phase, but the goal is to resume it as soon as hemostasis is considered stable, ideally within 5 to 7 days.
Even though resuming the second agent might slightly increase rebleeding risk.
Yes, because the data consistently shows that early reintroduction of the P2Y12 inhibitor, despite that potential bleeding risk, is associated with lower overall mortality due to the prevention of major cardiac events, especially stent thrombosis. We just cannot hold these agents for prolonged periods without a very compelling reason and cardiology agreement.
Okay, shifting gears to anticoagulants, things like warfarin or the DOACs, dabigatran, rivaroxaban, apixaban. Holding them during active bleeding seems obvious, but how quickly do we need to get them back on board?
Again, it's about balancing risks, and resumption needs to be prompt, especially for patients with a high underlying thrombotic risk.
Like who?
Patients with mechanical heart valves, those with a recent VTE within the last 3 months, or patients with atrial fibrillation who have a high CHADSVASC score.
So when should we restart?
The goal is to restart anticoagulation as soon as that thrombotic risk is judged to outweigh the immediate rebleeding risk. This often means restarting within maybe 3 to 7 days after endoscopic control, depending on the indication and the perceived stability of hemostasis. Delaying too long, even for a few days in high-risk AFib, significantly bumps up the stroke risk.
And what if the bleed is truly catastrophic, life-threatening, and maybe happening because of the anticoagulant?
Yeah.
Do we have reversal agents?
Yes. For severe, life-threatening bleeding where immediate reversal is needed to allow intervention or stabilization, we do have options. For warfarin, the standard reversal is usually with prothrombin complex concentrate, or PCC, which rapidly replaces the vitamin K-dependent clotting factors, plus vitamin K, of course.
And for the DOACs?
We have specific reversal agents now. For dabigatran, it's adalimumab. For the factor ZA inhibitors like apixaban and rivaroxaban, it's andexanet alpha. These are typically reserved for truly critical bleeding scenarios.
Okay, that covers the tricky area of antithrombotics.
Yeah.
Finally, to really have a lasting impact, we need to move beyond just stopping the acute bleed and address the underlying cause. This brings us to secondary prevention.
Absolutely. As we hinted at earlier, the success of the secondary prevention strategy is arguably the most critical factor determining the patient's long-term health and survival after a PUB episode.
And the first pillar of secondary prevention has to be dealing with H. pylori.
Without question. Every single patient who presents with PUB must be tested for H. pylori infection. It's standard protocol.
How's that testing usually done?
Typically, the initial testing is done via biopsy samples taken during the index endoscopy. That's quick, direct, and reliable. If those biopsies happen to be negative, maybe because of recent antibiotic or PPI use, or if clinical suspicion remains high, you might consider serology, or more commonly, non-invasive testing later on after discharge.
And if the test comes back positive?
Then eradication therapy is mandatory. Non-negotiable.
What does eradication therapy usually involve?
It typically involves a 14-day course of multiple medications. The standard first-line options now are often bismuth quadruple therapy.
Which is?
That's a PPI, bismuth, metronidazole, and tetracycline, taken together for 14 days. Or sometimes a concomitant quadruple therapy is used, involving a PPI plus 3 antibiotics like amoxicillin, clarithromycin, and metronidazole for 14 days.
And adherence is key.
Absolutely key. We need to provide really clear instructions and emphasize the importance of completing the full 2-week course.
Because the payoff for successfully eradicating H. pylori is enormous, right?
It's perhaps the single biggest impact intervention we can make for these patients long term. Successful eradication takes the risk of ulcer recurrence from a staggering 50% or 60%.
50 to 60% chance of it coming back.
Right, down to essentially 0 to 2%.
Wow.
It's basically curing that underlying driver of the ulcer disease for that huge subset of patients. A massive difference in their long-term prognosis.
But the job isn't done just by prescribing the antibiotics. We have to make sure the bug is actually gone.
That's the critical follow-up step that unfortunately sometimes gets missed. Confirmation of eradication testing is essential.
When should that be done?
It needs to be done at least 4 weeks after the patient finishes the antibiotics and any bismuth products, and ideally also 2 weeks after they've stopped taking their PPI.
Why the delay? Why the washout period?
Because both antibiotics and potent acid suppression can temporarily suppress the H. pylori without actually killing it. Testing too early can lead to a false negative result. You need that washout to be sure.
And how do we confirm eradication?
Usually with a non-invasive test like a urea breath test or a stool antigen test.
Okay, so H. pylori dealt with. What about secondary prevention for the NSAIDs and aspirin users? This often involves some difficult conversations.
It does, because you're balancing their need for pain or inflammation control or cardiovascular protection against the now proven risk of bleeding.
What's the primary goal?
The primary goal is always to discontinue the offending NSAIDs if at all possible. If the patient can stop the NSAIDs completely, the ulcer usually heals very well, often over 90% heal rate, and recurrence risk drops dramatically.
But what if they genuinely need continued anti-inflammatory therapy for chronic pain, rheumatoid arthritis?
Right. If stopping isn't feasible, then we absolutely must implement harm reduction strategies.
Which involves switching the type of ENST and adding protection.
Exactly. The recommendation is to switch them from a non-selective ENST to a COX2 selective agent, like celecoxib. These agents tend to spare that protective COX1 pathway in the gut lining. But crucially, even with a COX2 selective, you must rigorously co-prescribe a PPI for ongoing long-term gastroprotection.
So COX2 plus a PPI. And that PPI co-prescription, that becomes permanent for anyone who needs to stay on an ENST or even low-dose aspirin for secondary prevention, or DAPT.
That's the standard recommendation, yes. For anyone at high risk who must continue an ulcerogenic agent like NSAIDs or antiplatelets long-term, that PPI transitions from being a short-term treatment to a critical, long-term preventative measure to minimize the risk of recurrence. Chronic acid suppression is needed.
Okay, now what about that group where you do the endoscopy, you test for H. pylori, you ask about NSAIDs aspirin, and you find nothing? The idiopathic ulcers.
Yeah, that's a significant group. Maybe around 22% or so of PUB cases fall into this category, where despite a thorough workup, we just can't find an obvious cause like H. pylori or medication use.
Are these patients at higher risk?
They are generally considered a higher risk group for recurrence precisely because we haven't identified and removed a clear trigger. The underlying reason for their ulcer diathesis is unclear.
So how do we manage them long term?
Management typically involves ensuring complete healing with high-dose PPI therapy for a more extended period post-bleed, often 6 to 8 weeks. And then there needs to be serious consideration for longer-term, possibly even indefinite maintenance PPI therapy to prevent recurrence.
And presumably, you'd also want to be extra sure you haven't missed a less common cause.
Absolutely. Before labeling an ulcer truly idiopathic, you need to have meticulously ruled out other possibilities, things like Zollinger-Ellison syndrome, gastronoma, Crohn's disease involving the upper GI tract, malignancy, certain infections. A thorough investigation is warranted.
One last point on acute management, but it relates to follow-up. Maintaining vigilance for rebleeding, especially in those first 72 hours. How do we recognize recurrence, and what's the immediate plan?
Recurrence usually makes itself known through overt signs. The patient starts having hematomasis again, passes fresh melena, or shows signs of rapid hemodynamic instability. Maybe their systole drops, they become significantly tachycardic, or they suddenly need more volume resuscitation or blood.
If that happens, what's the sequence?
The sequence is firmly established. First, rapidly restabilize the patient, hemodynamically fluids, blood if needed. Then, repeat endoscopy is the first-line diagnostic and therapeutic intervention. Go back in.
Okay. And if that repeat scope also fails to achieve control?
Then, assuming the patient is stable enough for transfer and the procedure, TAE by interventional radiology becomes the next step.
And if both repeat endoscopy and TAE fail?
Then open surgical intervention becomes the final resort to definitively control the bleeding source.
Okay, that covers the spectrum incredibly well. So wrapping this all up, what does this entire evidence-based pathway mean for you, the hospitalist, managing acute PUB day to day? Let's quickly recap those 5 fundamental pillars we discussed.
That sounds good.
Yeah.
Pillar 1, rapid pre-endoscopic risk assessment using the GBS. Use it to gauge admission need and urgency.
Right. GBS first, pillar 2.
Aggressive initial resuscitation, but employing a restrictive red blood cell transfusion strategy targeting that HDB trigger of 70 to 80 grams per liter, or 7 to 8 grams per deciliter for most patients, remembering the exception for active cardiovascular disease.
Got it. Restrictive transfusion, pillar 3.
Judicious timing of endoscopy. Perform it early, yes, but within 24 hours, and, crucially, only after achieving adequate hemodynamic stabilization first, stabilize, then scope.
Pillar 4.
For those high-risk stigmata found on endoscopy based on the Force classification, mandatory dual endoscopic chemostasis, combining injection therapy, usually epinephrine, with the second modality, either thermal or mechanical like clips or OTSCs, and pillar 5, high-dose IV PPI therapy for a full 72 hours after successful endoscopic hemostasis for those high-risk lesions. Remembering that intermittent dosing is just as effective as continuous infusion, giving you flexibility.
Perfect summary. We spent a lot of time focused, rightly so, on the acute phase management, stopping the bleed, stabilizing the patient. But as we've emphasized throughout, those steps, while critical, are often just addressing the immediate crisis. Which brings us back around to our final provocative thought for today's deep dive.
Yeah, I think it's this. The single most critical factor determining a patient's long-term survival and well-being after an episode of PUB isn't necessarily the technical success of that first endoscopy, although that's vital. Rather, it's the comprehensive success of the secondary prevention strategy that follows. Did we meticulously test for and eradicate H. pylori? Did we appropriately address and modify their NSAIDs or aspirin use? And maybe most complexly, did we engage in that careful, individualized, often multidisciplinary decision-making process regarding the early and safe resumption of critical antithrombotic agents?
So it's the strategic planning, managing those competing life risks after the immediate fire is out.
Exactly. That planning the H. pylori eradication, the medication reconciliation and adjustment, the balancing of bleeding versus clotting risk, that is precisely where we as hospitalists provide the most profound, lasting, life-saving value for these patients long after they've left the endoscopy suite or even the hospital.
An incredibly detailed, thorough, and highly actionable review of PUB management from start to finish and beyond. Thank you so much for joining us on this deep dive today.